Thank you for the invitation. And I will talk about the spontaneous regression in Desmoid. I have no disclosure. I will briefly talk about the regression in Tumor and the regression in Desmoid in retrospective series, the experience of spontaneous regression in prospective studies and on clinical trials on drugs, and how spontaneous regression can occur in desmoid fibromatosis and the potential role of immune system. This will be the topic of my next talk. So the spontaneous regression in tumor is a rare phenomenon, and as reported by these authors in hepatocellular carcinoma, the mechanisms are unclear, and they claim for the potential role of tumor ischemia or systemic inflammatory response. In this second paper, authors describe temporary or prolonged clinical remission from cancers after SARS-CoV-2 infection, but they also described as a rare phenomenon, claim the potential role of immune response to COVID-19 in both tumor regression and progression. Regression in desmoid is not so uncommon, it's a common event, and this is one of radiological example of one of our patients who had the progression and then subsequent regression. Spontaneous regression in desmoid was described in retrospective series, and as recently published, they observed regression in monocentric series, then in a larger study population, in specific sites such as abdominal wall and extra-abdominal wall, and also in favorable and unfavorable location. And this led to the first consensus meeting published a long time ago, 2013, where authors claimed for wait and see as a frontline approach for the vast majority of patients. Then we published two more consensus paper, and the last was published in 2024. The experience of spontaneous regression was also observed in prospective studies and in clinical trial on drugs. In particular, in the recent last 2 years, we published 3 studies that were run parallel in Europe. They were prospective clinical trial on natural history of sporadic desmoid fibromatosis. Our study described the spontaneous regression in 25% of patients as initial event and in 1/3 after initial progression. The Dutch study described half of patients underwent that half of the patients who underwent progression had secondary decrease in tumor size, and in the French study, almost 2/3 of patients presented the spontaneous tumor regression or after an initial progression. In the first ever run trial on drug, on sorafenib, in the placebo arm, 2/3 of patients stabilized or presented the regression, which according to RECIST was significant in 20% of these cases. Sorry, I go back one. Okay. In this study, patients with progressive or recurrent tumors were included, and those patients had aggressive form of disease compared to those of to patients included in the prospective clinical studies on active surveillance, meaning that even if the aggressive form can show a progression, regression is not so uncommon after it. Also in the neurogagestat study, event-free at 2 years was 44% with placebo, and the proportion of patients who had an objective response with placebo was 8%. We are recently put together the data from the 3 prospective European observational studies in a pooled analysis. These data are not yet published, and we observed that initial tumor size, tumor location, and specific beta-catenin mutation were consistently associated with the probability of spontaneous regression, in particular, as can be imagined also, tumor less than 5 centimeters can have a spontaneous regression more frequently than tumor bigger. Patients who have abdominal wall desmoid have an increased probability of spontaneous regression, as well as patients with T41A. In this case, we observed that patients with S45F mutation had a lower probability of spontaneous tumor regression. Around 50% of all patients experience spontaneous regression, either as the first event or following progression. And regression according to RECIST as first event was observed in 1/3 of patients. And 3-year and 5-year RECIST regression was 24 and 32. And then I will talk about the role of immune system in my next talk.
Oh, we have some time. We have a couple of minutes for questions. Yes. So I can anyone have any questions? You want to ask? Because I can ask one. But who else has a question? Go ahead.
So it looks like the rate of spontaneous regression in the DeFi study was lower than many of the other studies that you cited. Is that the case, number one? And two, do you have an explanation for that?
Would you please repeat?
Yeah. In the neurogagestat basic study, it looks like the rate of spontaneous regression was lower. They reported 8% partial response in that study.
Yeah, according to RECIST.
Yeah.
Yeah.
In many of the other studies that you cited, the rate was around 25-30%. Do you have an explanation for that difference?
I think that the explanation can be related first of all about the different study population in the prospective clinical studies in the 3 European prospective clinical studies. We enrolled all consecutive patients, so patients at mostly at the beginning of their natural history. And in this, as I underlined, in this clinical trial, patients with aggressive maybe form were included, so were progressing patients. But I think that the meaning is that even if we had progressing patients, we could not forget about the regression. So we should keep in mind then that also in patients with progression, regression can occur.
Yeah, go ahead. Don't forget to introduce yourselves when you ask a question.
Thank you for the great talk. So, one of the things that always confused me with those things, so we're looking at specific genotypes, we're looking at specific genotypes, we're looking at location, but the tolerance for surveillance in those locations is likely to be different. The amount of time people are willing to watch a tumor in someone's neck versus in the abdominal wall is likely to be shorter. And then the genomics are different, right? Some of these mutations seem to occur more frequently in the extremities, for example, on the wall. So do you think that as a confounding argument, about how likely tumors are to spontaneously progress, but you're not going to walk through this long?
I think that a clinician should always evaluate the specific story of a patient, meaning the location, the size, patient feeling, pain. So it's not just a matter of dimension and location, but it's a matter of complexity. There is a patient, so I don't know if yeah, I think so. Maybe in Milan we have a feeling for spontaneous regression, so we try to keep patients more on watchful waiting, especially many years ago or some years ago, because we think that many desmoids will regress, but of course you cannot watch and wait all of them forever. At a certain point you should decide to treat. So for sure, for some location you cannot have the time span to see the regression, but maybe it also occur in some other location. No, it's not like this, because we observe spontaneous regression also there. It depends on not just on the location, because we know that in the extremity 45F is more common, and so it may regress in a low, it cannot regress so frequently, but if you can watch and wait, for sure you should do. Otherwise, you treat.
Great. I think those comments bring up the idea, when you're looking at any kind of a population, you look at the population in your study, and there's always biases depending on, if you're a hospital where you might see more children versus not, more extremities versus more central. So this is maybe more of a discussion question for later on. But with all the different groups and all the different cohorts of patients with desmoids, I wonder if there's some possibility of sort of combining them all together, trying to get as much data as available from them, and using some kind of maybe a different kind of analysis to see which ones regress and which ones don't. Yeah, or which factors might go along with regression, which factors may not, to be able to sort a lot of that kind of stuff out. So you remove a lot of those biases just because of populations people have. So that would be something we can talk about later. I don't think there's an answer to it. But maybe you have an answer. Do you have an answer?
I mean, we have already known that some desmoid will be more aggressive than others. So
yeah, but I wonder if we could get all the data from them. Maybe look differently.
These are data of 3 series, 300 patients. I think that there are a lot.
Yeah,
I mean, but
look at all things like, where they live, other other things that might go along with the families, using a big data approach. You get all the data on them, and use like a Google approach to how they would do it, to take a look at it and identify things that might go along. And then you take a second population and look at it.
Yeah.
Oh, go ahead. Nice question.
Yeah, thanks. Good talk. I was curious if you've seen any differences in regression based on age. Obviously, most of the studies that have been done and published prospectively have been on adults. Even within the adult range, curious if you've seen differences in the younger adult versus the older adult. The gestalt, at least in pediatrics, which is what I do and where I tend to live, is that there's probably less spontaneous regression. I mean, there hasn't been much. There was one prospective study done in Europe, and there was a pretty small percentage of patients that were observed that did spontaneously regress. But I was just even curious in the adult population. If you
we didn't find the difference in the age. No.
It was a great talk, a great discussion.